This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Epilepsia, published in 2026, titled Performance of the 5-Sense Score in a Pediatric and Young Adult Cohort of 100 Consecutive Stereoelectroencephalography Cases.
This is a timely paper, Alara. For those listening who are in the thick of epilepsy surgery rounds, you know the dilemma. We have a patient with drug-resistant epilepsy, or DRE, and the non-invasive workup isn't giving us that slam-dunk localization. So we turn to stereoelectroencephalography, or SEEG, to define the seizure onset zone. But SEEG isn't a guaranteed win. In fact, the literature suggests that in nearly half of pediatric cases in the U.S., SEEG fails to identify a resectable focus.
Exactly, Dr. Aris. And that's where the 5-sense score comes in. It was originally developed and validated in primarily adult cohorts to predict exactly that, when SEEG is unlikely to identify a focal seizure onset zone, or SOZ. A low score suggests a non-focal finding, which might guide a team to forego invasive monitoring altogether. But until this study from the team at Nationwide Children's Hospital, we didn't really know how it performed in a strictly pediatric and adolescent population.
It's an important distinction because, as we always say, children are not just small adults, especially in epilepsy. The etiologies are different, more focal cortical dysplasias, genetic issues, and perinatal insults compared to the hippocampal sclerosis or tumors we see in adults. Even the semiology is harder to pin down because a 5-year-old often lacks the expressive language to describe an aura.
Right. And even the logistics of SEE2 differ. In kids, we're dealing with thinner skulls that might limit rigid cranial fixation, and we're often managing the study under dexmedetomidine sedation. So the authors, led by Lindsay Trank and Adam Ostendorf, wanted to see if the 5-sense score holds up. They looked at 100 consecutive cases from 2017 to 2024.
Let's break down the score itself for the residents listening. What are the components they used for the calculation?
The 5-sense score ranges from 0 to 100. It's calculated using a publicly available online tool that incorporates data from the MRI, scalp EEG, seizure semiology, and neuropsychology testing. In this study, 2 investigators reviewed the conference summaries and assigned categorical values while remaining blinded to the actual SEEG results and the eventual angle outcomes.
And the magic number from the original adult studies was 37.6, right? A score below that predicted a non-focal SEEG.
Correct. So in this cohort, they grouped the results into focal, meaning a sublobar SOZ, and non-focal, which included multifocal or diffuse onsets. Out of the 100 cases, how did the score actually perform?
Well, the numbers are quite revealing. The 5-sense score had a sensitivity of 49% and a specificity of 75% for predicting a non-focal SEEG. The area under the curve, or AUC, was 0.673.
0.673. That's actually very comparable to the published adult validation cohorts. It's not a perfect predictor, but it's consistent. What I found particularly interesting was the age breakdown. They looked at children 13 years or younger versus those older than 13.
And the performance was essentially the same. That's a relief for those of us treating the younger pediatric population. It suggests that despite the challenges of eliciting semiology or the lower sensitivity of brain MRI in younger children, the integrated score remains a stable tool across the pediatric age spectrum.
I want to dive deeper into the ancillary testing because that's a huge part of our pre-surgical workup. They looked at FDG PET, SPECT, and MEG. How did those results correlate with the SEEG findings?
This was a major secondary objective of the study. They found that ancillary testing lateralized in agreement with a focal SEEG finding in 61% of patients. It had a specificity of 76%, but a fairly low sensitivity of 43%.
And did adding that ancillary data actually make the 5-sense score better?
That's the kicker. While the ancillary testing confirmed the 5-sense score, it did not significantly improve the sensitivity. The score, as it stands with just the standard MRI, EEG, semiology, and neuropsych data, seems to capture most of the predictive value.
That's an important point for resource management. But let's get to what the surgeons really care about, the outcome. If a patient has a high 5-sense score, does that mean they are more likely to be seizure-free after surgery?
The study says yes. They found that higher 5-cent scores were significantly associated with better angle outcomes with a p-value of 0.037. This is a vital piece of the puzzle. It's not just about whether the SEEG finds a focus, it's about whether that focus is the right focus for a successful resection.
It makes sense. If the non-invasive data is concordant enough to generate a high 5-cent score, our hypothesis for the SOZ is likely more robust, leading to a more effective surgical plan.
Exactly. But we have to be careful. The authors are very clear that the 5-cent score is a tool for patient selection, but it is not a sole predictor. A low score doesn't mean you automatically cancel the SEEG, and a high score doesn't mean the SEEG is a formality.
Right, because the sensitivity for predicting a non-focal SEEG was only 49%. If you relied only on the score to decide who not to implant, you might miss half of the patients who actually have a focal resectable SOZ.
That's a high false alarm rate if you're trying to avoid unnecessary surgery. However, the specificity of 75% is decent. It means if the score is high, you can be reasonably confident that the SEEG will yield something useful.
One thing that struck me in the paper was the mention of neuroplasticity in children. They noted that treatment surgeries in children can leverage enhanced neuroplasticity, which sometimes allows for larger resections or even the destruction of eloquent cortex that we wouldn't dream of in an adult. Does that change how we interpret a non-focal SEEG?
It might. If the SEEG shows a broad but still somewhat regional onset, we might be more aggressive in a child. The paper mentions that despite the differences in surgical strategies and etiologies, the seizure outcomes after SEEG in children are remarkably similar to adults. This validation of the 5-cent score reinforces that the underlying principles of identifying the SOZ are universal, even if the brain we're working on is still developing.
So, Dr. Aris, if a resident comes to you in the epilepsy conference tomorrow with a 12-year-old patient who has an ill-defined MRI and non-lateralizing scalp EEG, and they've calculated a 5-cent score of 25, what's the move?
Well, based on this study, that score of 25, which is below the 37.6 threshold, should make the team pause. It's a red flag that the SEEG has a higher probability of being non-focal. We should look at our ancillary testing, the PET or the MEG, to see if they lateralize. If everything is pointing toward a diffuse or multifocal process, the 5-cent score gives us the objective data to have a very honest conversation with the family about the likelihood of a successful surgical outcome.
It shifts the conversation from let's just put the electrodes in and see to a more data-driven risk-benefit analysis.
Exactly. And conversely, if that patient had a score of 60, even with a challenging semiology, we'd feel much more confident that the SEEG will define a sublobar focus that we can actually treat.
To summarize for our listeners, this study of 100 consecutive cases confirms that the 5-cent score is a valid clinical tool for the pediatric and young adult population. It performs with an AUC of 0.673, which is on par with adult data. It's particularly useful for predicting non-focal SEEG findings and correlates well with post-surgical angle outcomes.
But remember, it's an adjunct. Use the online calculator, look at the MRI and the EEG, but don't ignore your clinical judgment. Pediatric epilepsy is complex, and while the 5-cent score improves our selection process, it's one part of a multidisciplinary decision.
This was a great dive into the data. It's always encouraging to see adult-validated tools being rigorously tested in the pediatric space.
Absolutely. Well, that's all the time we have for today's episode of the Neurosurgery How podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next one.
Keep operating and keep learning.